Welcome to part 3 of Mastering the CMS Initiative. In this section, we're going to move from what the program requires to how hospitals can actually prepare their teams to meet those expectations. So this is where policy becomes practice. Before we dive in, let's briefly recap what we covered in part 2. We discussed the impact of the model on surgical care. We reviewed the broad scope of procedures included, such as orthopedic, general, cardiac, neurological, gynecologic, and urologic surgeries. We defined the surgical episode from pre-admission through 30 days post-discharge. And we also looked at the quality matrix CMS will use to measure success: clinical outcomes, process utilization, patient experience, and resource use. We also talked about the risk of non-compliance, including penalties, survey scrutiny, and damage to reputation. With that context in mind, let's turn to part 3, how to prepare our clinical teams for success. For those of you joining me for the first time, my name is Aisha Kulor, and I serve as the Chief Clinical Officer or Chief Nurse Executive for the Institute of Post-Acute Care. I bring with me 2 decades of experience. I have worked as a Chief Nursing Officer, Regional Director, Consultant, and nurse leader supporting hospitals in regulatory compliance as well as CMS readiness. In this section, I am going to guide you through strategies to align your staff, your frontline nurses, physicians, therapists, pharmacists, and case managers with the expectations of this new module. Mastering the CMS Team Initiative, transforming surgical care payment models. This section is part of a broader training series designed to guide hospitals and administrators through the CMS Transforming Episode Accountability Model or TEAM. This goes into effect January 1, 2026. Part 3 is going to focus specifically on preparing clinical teams, equipping your staff with the knowledge, strategies, and tools needed to meet compliance standards and deliver safe, coordinated surgical care under this module. Here's what we'll cover in part 3. Staff education strategies that equip each role with the knowledge and tools needed. Enhancing care coordination across disciplines to reduce silos and improve outcomes. Documentation excellence, because if it's not documented, CMS considers it as not done. Assessing your operational readiness through gap analysis, process redesign, mock audits, and finally, creating a culture of compliance so success is sustained across time. Let's start with how to prepare your staff through education and training. Preparing your clinical teams. So under teams, success will require comprehensive staff education, enhanced interdisciplinary collaboration, and operational readiness. Let's explore strategies to align your teams with these new expectations. Education is going to be the foundation of your readiness. Staff must be trained not only in what the module requires, but why it's important. Training should be role specifics. Surgeons will need to understand how outcomes tie directly to reimbursement. Nurses will need clarity on discharge documentation as well as patient education. Case managers must know their role in reducing readmissions, and pharmacists must ensure medication reconciliation is accurate as well as timely. Education should also be practical, delivered through simulations, case-based learning, ongoing refreshers, not just a one-time training session. This way, your staff is able to practice what to do in real scenarios before patients are impacted. This is where organizations such as Relias can be leveraged. Relias provides hospitals with tailored training modules, competency tracking, and real-time reporting. Leaders can assign specific courses to staff by roles such as infection prevention for surgical nurses or discharge planning for case managers, and then monitor the completion across the organization. This ensures consistency, accountability, and readiness well before January 2026. Remember, when staff education is role-specific, practical, and supported by platforms such as Relias, your hospital positions themselves for consistent compliance and stronger outcomes. Enhancing care coordination. So, as I have said over and over again, success under this model depends on strong collaboration across disciplines. No single department can achieve compliance alone. It requires a coordinated effort from your entire team. This means breaking down silos, building in daily interdisciplinary rounds for surgical patients, ensuring there's a shared accountability for outcomes. Care can no longer be divided into isolated responsibilities. It has to be a function as a connected whole. Communication must also flow across settings from inpatient, outpatient, post-acute, so that every provider working with the patient has the exact same information. Developing joint clinical pathways will ensure consistency and prevent gaps in care. Let's look at an example. One hospital improved cardiac surgery outcomes by introducing daily huddles with the surgeons, nurses, pharmacists, and case managers. These brief but structured conversations reduced delays in medication reconciliation and streamlined the discharge planning, which directly decreased their readmission. Early discharge planning. This must be started at admission and evolve across the surgical journey. On the day of admission, it's important to complete a risk assessment and identify any barriers that the patient may have. Post-surgery, you want to update the plan based on the surgical findings and involve your entire interdisciplinary team. During the hospital stay, you want to monitor discharge readiness on a daily basis. And then on the day of discharge, it will become imperative to provide instructions, medication education, and confirm support for the patient at home during that 30-day time frame. Once the patient is discharged, make follow-up calls, transition information to the next provider, and monitor for complications. Some hospitals have adopted a first-day home call to check medication availability and confirm follow-up appointments. This small step has significantly reduced their 30-day readmission rate. Documentation is going to be important, and documentation is truly the foundation of team success. CMS will validate compliance not only through claims data, but also through your medical records. Remember, if it's not documented, it's not done. And that is exactly what CMS is going to assume. This means certain elements have to be airtight every single time. Your comprehensive risk assessments and care plans should clearly show the patient's needs and how it was addressed. Complete operative notes with detailed clinical information, discharge instructions specifically tailored to the patient, not just generic handouts, documented post-discharge plans and follow-ups, including referrals as well as scheduled appointments, thorough medication reconciliation at every transition point, and patient education with teachback so we can demonstrate the patient not only received the information, but they also understood it. From my perspective as a nurse executive, I have seen hospitals fail surveys not because the care was not given, but because the documentation did not prove it. So one of the hardest lessons to teach frontline staff is that excellent care still counts as incomplete if it's not written down. I once reviewed a case where a nurse provided thorough wound care education but didn't document the patient's teachback. When the chart was reviewed, it appeared no education had been provided. That gap alone created compliance risk, even though the nurse had done the work. The bottom line is this: documentation doesn't just reflect care, it protects the hospital, validates outcomes, proves compliance, and it's as important as the care itself. You need to assess your operational readiness as we move into 2026. So to prepare for this, hospitals must actively test their systems before this deadline. This isn't just about asking, are we ready? It's also about proving readiness through structured assessment. There are 4 key steps that I will recommend. Gap analysis. Review your current workflows. Identify where they fall short of CMS requirements. So this will include areas like your discharge documentation, follow-up coordination, and patient education. Process redesign. Once you've identified the gaps, redesign your workflows with standardized protocols so there's no ambiguity in what to expect. Mock audits. Use CMS criteria to simulate a real audit. Have consistent chart reviews. Check discharge summaries. Validates whether documentation will stand up to severe scrutiny. Performance monitoring is going to be key. Build dashboards that track compliance in real time. This allows leaders to quickly see where the problems are happening and address them before penalties are applied. An example is a hospital was preparing for a hip replacement case. They ran a mock audit on 30 recent discharges. They discovered that while patients had been educated on mobility, less than half of them had documentation of medication reconciliation completed at the time of discharge. By redesigning the workflow, adding a mandatory electronic prompt for reconciliation in the EHR, they were able to close that gap. This is how readiness is proven, not just by making the assumption, but by testing, finding the gaps, and fixing them before CMS does. So creating a culture of compliance is going to be important. Finally, we must talk about the culture. Sustained readiness is never achieved through policies alone. You can have the best checklists and protocols, but if the organizational culture does not support compliance, those tools will not be enough. Creating a culture of compliance means weaving it into your daily practices so it becomes part of how care is delivered and not an afterthought or an extra burden. Again, from my perspective as chief nurse executive, I have seen that it always starts with leadership. When leaders are visible, when they round with staff, and when they demonstrate that compliance is tied directly to patient safety, the buy-in from the staff is much faster. It also requires regular feedback at the unit level. So in my own work, I have seen teams improve almost immediately when they can see their data, whether it's their readmission rate, documentation accuracy, or infection prevention. Data makes the expectations real and actionable. Clear accountability is equally important. Every discipline needs to know exactly what they own, and leaders need systems in place to monitor and coach performance. Finally, recognition cannot be understated. I have made it a practice to call out units or individuals who consistently meet compliance expectations. That recognition, whether public in a meeting or private in a note, builds morale and reinforces the right behaviors. A strong compliance culture doesn't just meet CMS standards. It creates safer systems, improves reliability, and strengthens your staff engagement. And when your staff sees leadership invested and supportive, they stop viewing compliance as a burden and they start embracing it as part of their professional excellence. So, to summarize part 3, we started with staff education, making sure every role has the knowledge and tools they need. We moved into care coordination, breaking down silos and ensuring smooth handoffs. We emphasized the importance of complete and precise documentation, since CMS will validate this through your claims and medical records. And we also highlighted operational readiness using gap analysis, process redesign, mock audits to uncover weaknesses before the penalties begin. This step is critical. Hospitals that assume readiness often discover gaps too late. Those that test, redesign, and monitor performance are the ones positioned for success. And finally, we talked about creating a culture of compliance. And this is a mindset where meeting CMS requirement isn't just a checklist item, but part of your everyday practice. In part 4, we will build on this foundation by looking at how technology and training platforms can reinforce these efforts. Because readiness isn't sustainable without systems that prompt your staff, track compliance, and make the right actions easier to take.